Well, good morning. It's a lot of information to assimilate. I hope that we're doing all right, and I hope not too many of you need a cup of coffee right now to help assimilate this information. As you know, I'm a member of the ILSI Caffeine Systematic Review Team. I received an honorarium and travel funds to attend this meeting. I have no conflicts to disclose. A word about what I do. I'm a medical toxicologist. As you know, there's many different realms within the term toxicology. There are research toxicologists, analytical toxicologists, veterinary toxicologists, regulatory toxicologists, and the list goes on. People within my discipline deal with acute overdoses of drugs or chemicals. So chiefly what we're dealing with are individuals who are misusing, abusing substances for recreational purposes, or people who have mental health issues and have done a suicidal gesture. So this is quite different than performing studies in the lab or in your clinic to look at the effects of drugs. What we're dealing with is anecdotal case reports, and the reflection of that you'll see in our confidence with our findings is going to be much lower than that of that you've heard from all of my colleagues. That's just the way it is because of the data that we have at our disposal. The important point is that we're looking at a lot of case reports, which is normally not done in systematic reviews, but this is the best evidence that we have. So that's why it was included, and it's the best evidence one will ever have. This is not just for caffeine, this is for virtually any drug or chemical that you may wish to consider. So this is the same paradigm that all of my colleagues have showed. The chief questions that we're asking is for healthy adults is caffeine intake over 400 milligrams per day compared to intakes less than that associated with adverse outcomes, and the key number for death was 10 grams. Is that associated with death? We looked at 46 studies. 20 were excluded for various reasons, and as I've already indicated to you, they were all case reports, very tiny case series, 2 or 3 being reported. The populations we were concerned with were everything in the mandate. And again, they're mostly self-reports with poor exposure calculation. Someone who's just done a suicidal gesture or someone who's misusing or abusing a drug, by definition, is not a valid historian in terms of dose. There were a few repeated exposures. Half of them were specifically caffeine, either powders or tablets. Others involved energy drinks or cola. The outcomes of concern, of course, were death and non-fatal effects associated with suicide attempts or high-dose related events. The concerns we had, of course, were cardiovascular, nausea, vomiting, seizures, and hypokalemia. And again, considerations regarding fatal dose. For all drugs, published doses are not precise. For reasons that I've just shared with you. Data based on observations of isolated anecdotal events. This is not the scientific method of doing a double-blind, randomized clinical trial. Obviously, we can't give one group of patients certain doses of caffeine and see how much it takes to kill them. That's why we rely on case reports. These considerations also apply to establishing the adverse effects dose. So here's the plot, and you can see for death, you can see virtually all points are the right of 10 grams. So the evidence demonstrates that in adolescents and adults, death occurs at doses mostly greater than 10 grams. Most exposures were suicidal gestures. Adverse effects in non-fatal cases included nausea, vomiting, and cardiovascular events. The exposure characterization was poor. Again, for the reasons I've already shared with you, we're relying on someone who didn't really care how much they took, or is too emotionally upset to accurately give you the dose, etc. That's why we have very low level of confidence in the evidence. One bias that cannot be measured is publication bias, and that's always an issue once a certain level or what have you is established in the literature. It's difficult to get something below that particular level or comparator published, either because you don't submit it or the editorial reviewers don't accept it. And we have no way of knowing the effect of publication bias upon these data. Similarly, the scatter diagram for non-fatal effects, virtually all of them are to the right of the 400 milligrams. Reporting bias due to nature of study types, again, as before, is a concern. Adverse effects typically included nausea, vomiting, hypokalemia, seizures, and cardiovascular events such as tachycardia, palpitations, and changes in blood pressure. And for reasons that I've already mentioned more than once, exposure characterization is poor, very low to low level of confidence in this body of evidence. There is one thing that's very important here, in that all of these exposures are 400 milligrams as a single event, whereas we're looking at 400 milligrams per day. So this should give us a little more comfort and confidence with this specific number. Obviously, if you take 400 milligrams in one dose, you're going to have a much higher blood concentration than taking 400 milligrams in divided doses over that day, such as 2 cups of coffee now, another cup at lunch, and 2 more cups at dinner time. So that should give a little more comfort with this observation. Here's the heat map, not dissimilar from several that you've already seen from my colleagues. The overall high risk of bias for studies in adults, few qualified studies in other populations, none in children. The question 8 and question 11 were the ones of particular concern. Again, these are unintended, so the dose was not controlled, and the other is purity. We're not 100% sure that it's always caffeine and nothing else that might have been in the coffee or who knows what. So you can see quite a lot with Q8 and Q11. You can see quite a lot of red and quite a lot of pink. And as I said, this is the bias as measured by the tools that Dr. Myers shared with us. And again, publication bias would not be part of this. Factors that increased or decreased the confidence in the body of evidence by endpoint. I'll again ask you to focus on the extreme right, where everything is very low to low for the reasons that I've already shared with you. But one thing that should give us comfort is the column next to that, the second from the right, where there's quite a amount of consistency for both the deaths at greater than 10. Remember the scatter diagram or forest plot that we showed, and equally the same comment for other acute effects. And my last comment applies to other acute effects. All of this is 400 milligrams or greater as one dose, not spread throughout the day. So in conclusion, regarding the weight of evidence, in adults, when the weight of evidence was considered, 400 milligrams of caffeine per day, which is 2.5 milligrams per kilogram per day for adolescents, was not associated with acute adverse effects. There's a wide range of adverse effects observed across cases with overlap. Death has been associated with acute exposures of 10 grams or more, only a single report of less than 10 grams. Acute effects may be the result of rapid consumption and do not represent typical consumer behavior. And again, that's just turning my comment around in a different way about taking it all at once rather than divided doses throughout the day. We have no, insufficient evidence for pregnant women and children, and didn't want to again bore you with that same table that we've seen several times, but if you really want to see it, it's in the manuscript. That's the footnote in the bottom right-hand corner. In terms of future research needs, of course, whenever we're discussing a contentious issue, there's always the need for more research. In this area, as I said, the research is always going to be anecdotal observations, but many of the anecdotal observations were not even supported by blood concentration determinations, so that certainly would be a good thing, both qualitatively and quantitatively. Qualitatively to confirm that at least there's caffeine in this patient, and it's not just there by verbal report, and quantitatively, if we can get enough of these reports to try to correlate blood concentrations with clinical effects. So with that, I'd like to thank you very much for your kind attention, and I'll turn the microphone back to our chairperson.